Thank you for the kind introduction and good afternoon, everyone. Thanks for being here. The title of my talk is History Repeating, Guidelines to Address Common Problems in Psychedelic Science. And I think I am invited to play the devil's advocate, which I'll try to do my best. But first, maybe a bit of personal disclosure. I'm on the board of Open Foundation and also co-organizer of ICPR. But maybe it might also be good to know where I come from with my skeptical or critical perspective. So first about my history repeating. This is me as a fresh bee doing my PhD work. So I have a background in cognitive neuroscience at the Donders Institute in the Netherlands, doing basic research on perception and action coupling. Then I moved on actually with a postdoc in Switzerland, in Lausanne at the EPFL, together with Olaf Blanke, doing research on body perception and out-of-body experiences. And then I moved on with a research grant by the Dutch government focusing on mystical type experiences using a placebo God helmet. So we have developed a helmet that allegedly is capable of stimulating your brain. And we found that through suggestion alone, people can have mystical experiences without ingesting any psychedelic substance. But at the same time, I was affiliated in the social psychology department of my university. And this was at the time of the replication crisis that hit the field really hard. It turned out that approximately 2/3 of all findings were not replicable. And this triggered me to pursue the replication of published studies within the field of religion and spirituality. So we've ran 2 projects, the Religious Replication Project and the Open Science of Religion Project. And this caused reason for concern because many findings that were taken for granted actually turned out not to be replicable. And that causes, of course, a problem for the field. And then, since 2021, I developed an interest in psychedelics as well. Personal, but also professional. I started doing research on these topics. And the same problems that I was witnessing at the time with the research in social psychology and religion and spirituality, I also witnessed in the field of psychedelic science. Basically, a lot of questionable research practices, findings that are questionable, and this has triggered my skeptical outlook on the field, which I will share today, but I also hope to bring a more positive message in terms of how we can improve the field. So what I will do is I will first provide a very short introduction. What is at stake here? Then I'll shortly address the 10 most pressing problems for psychedelic science. And then in the third part, I'll end with some solutions for each of these problems and end with general recommendations and the outlook for what the field might look like in the next 10 years or so. But first, the introduction. As we know, in the 1950s and 60s, a lot of research was already conducted on quite similar indications and applications of psychedelic therapy that are also being investigated today. So the use of LSD for alcohol use disorder, depression, end-of-life anxiety, and narcotic addiction, and psychoneurosis, including depression. As we also all know, common saying has it that due to psychedelics getting out of the lab, the emergence of counterculture, protests, the Vietnam War, etc., psychedelics were banned, and we encountered a war on drug. And these substances were put on Schedule 1, they were classified, hence rendering it more difficult to conduct research on psychedelics. And there's been a silence for almost 40 years. At least that's the common wisdom. But is that actually the case? Or could that only be part of the story, that the war on drugs is actually the cause of psychedelic trials to end prematurely? Because another perspective could be that researchers lost interest in psychedelics simply because of disappointing results. And for this perspective, I have also to credit Thorsten Passy, a psychiatrist from Germany, who brought to my attention again the relevance of the early trials on psychedelics. Because if you look at those early trials, it is actually interesting to see that, this is not the slide I was looking for, this is looking a bit messy, but if you look at the early studies, that the typical story of those early studies is that the quality of those early studies is really poor and that they don't meet up to the quality criteria that we have today. But at the same time, if you closely scrutinize those studies, it actually turns out that those studies weren't that bad after all. They had quite high sample sizes, quite good control conditions, they made use of active placebos, they systematically tried to manipulate the psychotherapy component using 1-dose sessions or multiple dosing sessions, very extensive psychotherapy afterwards. So I've included a couple of examples, but unfortunately it doesn't show up, the right quotes don't show up here. But for instance, an example study that is included is the study by Ludwig, that had a high sample size, different control conditions, long-term follow-up measurements, up to 1 year after the treatment, triangulation, not only by self-reports by patients on drinking behavior, but also by family members and friends to assess whether they were really abstinent, proper blinding, and according to a recent meta-analysis, a low risk of bias. But at the same time, after discharge, a follow-up was regarded successful only when the patient could be interviewed. Sorry, the slides are messed up, so I'm a bit confused. Let me retake. Let's see if the next one actually is showing what it should show. What came out of these studies? That is actually the most interesting. So this is the study reported to by Ludwig. The conclusion of this specific study was comparison among the treatment groups failed to show any consistent significant differences. So overall, all the different groups improved in terms of therapeutic outcomes. But this indicated that there was an overall improvement for all groups, but irrespective of whether the groups received LSD or not. And again, the slides are messed up, but basically, if you closely read the quotes in the original paper, the concluding remarks of the author read like, well, initially we were hopeful and really anticipating that LSD therapy might work for these patients. But we cannot conclude anything else beyond that, unfortunately, LSD therapy does not provide the benefits that we were hoping for. Now, this is, of course, only one study. But then if you look at multiple studies, so here's just a list of studies that basically published null findings already at the time. So they repeatedly show again and again that LSD therapy didn't work better than conventional therapy forms or treatment as usual. So I think this is actually quite a shocking insight. Or at least there were no measurable effects of the therapy beyond 6 months. So patients slowly and gradually improved for the first 3 months, but then they relapsed and got back to their drinking behavior as they were before. And this is despite quite a high heterogeneity. So even though the study designs were quite different, there's one conclusion that they converge on, and that is that LSD did not outperform other treatment forms. Now you might question, how can this be? How can this have been overlooked in, for instance, the famous meta-analysis by Krebs and colleagues of 2012? So this is a highly cited meta-analysis that has gained a lot of citations in the field, because they also reviewed the early studies of the 1960s, and they actually concluded that psychedelic therapy is effective and has long-term effects. How can this be reconciled? Well, it turns out that according to a recent reanalysis of the original data, that there were a couple of statistical and methodological flaws in the Krebs et al. Meta-analysis, resulting in an overestimation of the effect sizes. So Sikinago and colleagues redid the analysis and also re-evaluated all the original studies. They found effects of psilocybin and LSD therapy on drinking behavior at 3 months, but no persistent effects at 6 months and at 12 months. So that puts the findings again in a different perspective. Also here, unfortunately, the relevant quotes are messed up. So I'll skip over this. But what the quotes were meant to show is that if you again closely read the paper, and in this case this is the paper by Hollister, the quotes are saying, well, all these results are actually showing that LSD therapy is not as effective as we were hoping for, and at the same time that all the studies we have suffer from the common problems, including the breaking blind, patients having expectations, selection bias, etc. So while I was reading through this literature, I actually came to the shocking conclusion, it is history repeating all over again. The things that we discuss these days about the shortcomings of psychedelic clinical trials were already exactly anticipated 50 years ago. The paper could read as if it has been published yesterday, and that is actually quite shocking. So could that indicate that indeed psychedelic therapy was left behind because it was ineffective and not necessarily due to the war on drugs? Well, I think it's too early to conclude that it is ineffective, but I think that based on all the concerns that I will discuss today, we might need to rethink how we apply psychedelic therapy, and we might need a paradigm shift in the field. So let me shortly go to the methodological problems in psychedelic science. What are those problems? If you want to find out more and a more detailed version of this presentation, here's a link to the paper that we published on the topics, and also a couple of online webinars that we made available. For those interested, here's a QR code that directs you directly to the slides of this presentation as well. So you can download the presentation if you want, and also look up the links that were provided. So I'll try to keep the slide on for a minute so you can look it up. But basically the content of this is covered in the paper that we published with the same title, History Repeating, and also an extended version of this talk is available on YouTube as well. And in this paper, we addressed the 10 problems in psychedelic science. And these problems, again, are not unique. They were already anticipated in the early trials in the 1960s. But also many other researchers have made the same critiques. I think the paper is unique in trying to synthesize all those findings in a kind of coherent classification. And we classify the problems as easy, moderate, and hard. And that is defined in terms of how easy or moderate or difficult they are to solve in terms of scientific rigor, money, resources, and scientific breakthroughs. And together, these problems threaten things that we deem really relevant for any scientific study, namely internal validity. Are your conclusions valid? External validity. Do your conclusions generalize to the population that you intend to generalize about? Statistical conclusion validity. Are your conclusions valid in light of the statistical evidence? And construct validity. Are you actually measuring what you intend to measure? Well, these problems are mainly phrased and focused on discussing the research on randomized controlled trials in psychedelic therapy. But they also affect basic research on the neural mechanisms or the pharmacological mechanisms underlying the working of psychedelics. And here are the 10 challenges that we identified. Invalid inferences, conflict of interest, safety as the easy problems, control groups, sample sizes, selection bias, study duration as the moderate problems, and breaking blind, placebo effects, and mechanisms as the hard problems. And of course, the distinction is a bit arbitrary, but it is primarily meant to illustrate that with unlimited money and unlimited resources, you could, of course, address a couple of these problems, but then still the hard problems remain because they are at the very basis of psychedelic therapy, and they're very difficult to address. So what I will do in the next 10 minutes or so is shortly go over each of these problems. First off, invalid statistical inferences. These are characterized by questionable research practices, consisting of, for instance, switching off primary and secondary outcome measures. Things that are called a pre-registration, but that are not specific enough to really count as a valid pre-registration. So flexible pre-registration up to 12 weeks instead of at 12 weeks we will measure the effect of the therapy. Multiple testing, a problem that is frequently encountered but not properly controlled for. The false positive rate is not effectively controlled for. Selectively removing outliers, using one-sided over two-sided tests. These are questionable research practices that are already known for a very long time and that have also contributed to the replication crisis in psychology, resulting in conclusions that are actually in contrast with the evidence. And also a lack of transparency about the questions or about how the inferences led to actually the findings that were reported in the paper. And in the history repeating paper, we list a couple of examples to illustrate these problems. Not to name and shame, but simply to illustrate, well, these problems are quite widespread. So we have a problem here in terms of like careful statistical reporting that should be addressed. Conflicts of interest. Many studies in psychedelic science are funded by philanthropic organizations, but also by pharmaceutical companies who might have a vested interest in the outcomes of the study. They're not a red flag per se. Of course, we need the money of those supporters to actually conduct this research, but it turns out that conflict of interest studies work 5 times better than studies without a conflict of interest. So this introduces bias. They're very common in this literature, so sometimes the conflict of interest section is actually longer than the scientific paper itself, the disclosure statements. And they're sometimes hidden behind a paywall, but it is very important to be very specific about this. And especially in the evaluation of manuscripts, we need more independent experts that are not funded by anyone except by the journal who might pay them for their services. Conflicts of interest also extend to the role we have as therapists and researchers, because we might also have our own agenda and bias, consciously or unconsciously, that might affect the results. Especially in the field of psychedelics, there are many psychedelic enthusiasts, including myself, but that brings in bias, and we need to safeguard ourselves against the bias that we might have in looking for positive outcomes and positive results. Safety and adverse events. Third problem. Last year, Joost Breeksema gave a talk on this topic. He has identified that in many clinical trials, there's a lack of systematic reporting about safety of psychedelic trials. But there are many safety and adverse events that could occur. Just a list: risk for sexual abuse, induction of false memories, increased suggestibility, ontological shocks, the possibility of false insights or placebo insights. But also it is acknowledged that more and more that patients after, but also general people after taking a psychedelic suffer from adverse after effects that so far have been ignored, including recurring hallucinations, feelings of dissociation or derealization, increased anxiety, physiological discomfort, but also existential stress. People that have very profound experience, but then they're back in their home with family members who don't understand what they're talking about. Hence the importance of what Rosalind Watts was talking about, of integration and therapy groups and support groups for those people. But we're currently lacking those in many of the clinical trials. The lack of control groups. This is labeled a moderate problem. Open label studies. We see a lot of open label studies in the field, especially for treating new conditions that have not been treated or investigated before. But they're fairly uninformative without a control group, especially given the cyclic nature of a lot of psychopathologies. So for instance, it is estimated that without any therapy, people with a major depressive episode will recover spontaneously in a year, 53%. So even if you don't do anything, you can already see a 53% improvement. So that's something to be aware of, especially because there might also be a regression to the mean, which means that there might be a decrease in scores over time due to selecting people based on extreme values, such as the threshold on depression severity. So people are enrolled in clinical trials in their worst phase, but based on natural variability, you might have expected those people to improve anyway. So you need a control group to make sure that your therapy works better than treatment as usual or without treatment. Sample sizes. Especially early studies and early clinical studies are characterized by small sample sizes and an overestimation of the effect sizes. And again, this provides a threat to statistical conclusion and external validity, because what can we conclude about the general population of depressive people based on a study of only 8 depressive patients? It turns out that in clinical psychology, 60 to 90% of the studies, also phase 2 and phase 3 studies, do not replicate well. So also 55% of phase 3 studies do not even replicate, due to a lot of variability, likely in the patient characteristics. And this results in, indeed, what Helena Eicher was already referring to earlier, in the shrinking of effect sizes over time. So this is a pattern that is typically seen for any therapy form. Like there's a new therapy, the initial studies with small sample sizes represented by small circles report very large effect sizes. But then over time, as people are able to set up larger studies, large-scale studies, the effect sizes approximate more realistic estimates of the effect size, due to many reasons. We did this analysis also for psychedelics. It is difficult to see really a trend here, and there was not a positive correlation, but you can see that over time, we also see a progression towards more high-powered studies with bigger sample sizes, and also probably towards a more realistic estimation of the true effect size, which resembles more effect sizes seen for other therapy forms, rather than the extreme effect sizes seen in the early studies. Also a potential problem, publication bias. So this is a recent meta-analysis that came out of psychedelic trials for the treatment of depression, indicating that especially studies reporting a large effect size were overrepresented, and studies on the other hand were underrepresented. So there's an asymmetry in the funnel plot, which is typically taken as an indication that there's publication bias going on. So studies not finding a positive effect with small sample sizes were not reported. So that's a problem as well for the field. The sixth problem, selection bias. In many psychedelic studies, only people interested in taking a psychedelic obviously are included. And that increases expectancies and responses, and also placebo effects, and might result in an overestimation and an increased effect size. But also the long list of exclusion criteria for clinical psychedelic trials might introduce bias and may increase treatment efficacy because selected samples are less severely ill, no comorbidities, no suicidal ideation, and more motivated. And a recent meta-analysis actually indicated that indeed prior experiences with psychedelics have an effect on treatment responsiveness. because it was found that patients with a history of psilocybin showed a more pronounced effect in the therapy, probably based on positive expectations, associations, and less anxiety during the treatment. So if we want to make psychedelic therapy available to the population at large, the question is, can we really make that inference? Or is this only a therapy for patients or people already having some interest in exploring this therapy form? Study duration, already alluded to when discussing the early studies on psychedelic therapy from the 60s. The target are, for instance, treatment-resistant populations, but the follow-up durations are often very short. Or if they're long, they typically show that there's a temporary improvement, which might well be related to a psychedelic afterglow. But if you look longer than 6 weeks or 3 months, there are no sustained improvements. And this is also a problem for contemporary trials that typically don't have follow-up measurements beyond 8 weeks or 3 months at most. So the vast majority of the literature at best demonstrates short-term symptom reduction, but not treatment, and not the curing of depression, anxiety, etc. So those are the moderate problems. They might be solvable with more effort, including control conditions, including long-term follow-up measurements, including more participants, more representative participants. But the real problems are, of course, more difficult to address. The breaking blind problem. So blinding is at the very basis, at the very logic of randomized controlled trials. But in many cases in psychedelic trials, as we know, blinding is broken because the clinical interviewer is not blind, may in turn provide more or better care. I've spoken to therapists in randomized controlled trials saying if they know their patient got psilocybin or MDMA, then they know the magic is about to happen. But if you find out that your patient is in a placebo group, then you're up for a long and boring session. That brings in, of course, bias and motivation as well, reduced motivation. But also the participant is often unblinded. Well, that is, of course, in and of itself a problem, but then the problem is even worse if it is not reported, and that is oversight in many clinical trials that have been published, that only 8 out of 81 studies actually reported whether participants and clinicians and experimenters broke the blind. And if they reported, they actually often indicated that indeed the blind was broken and that this was a problem. And recently it was also pointed out that inner placebos are also insufficient to control for expectancy effects. So simply giving a placebo actually can exaggerate the problem because it can induce placebo effects, but also nocebo effects if you have patients who are disappointed in getting a placebo instead of the real deal, so to say. So the breaking blind problem ties in with placebo effects. I already told you about the experience or the experiments with the God helmet. If you give people a helmet and you tell them it will stimulate your brain, about 50% of the people will have a mystical type experience. So expectations about what a treatment will do already can induce mystical type effects. And similarly in psychedelic therapy, patients' expectations have an effect on treatment efficacy, especially in combination with psychedelics. It has been suggested that psychedelics make people even more suggestible and hence might act as super placebos. They can actually amplify the placebo response. There's a famous paper, Tripping on Nothing, also showing that if you give people placebo psychedelics, some of the participants also have a full-blown psychedelic experience, even without receiving any active drug at all. And also the media hype might contribute to this, because based on the exaggerated stories out there in media outlets, people also have high expectations about what a psychedelic will do, resulting in probably a more profound experience than without those expectations. So that's on behalf of the patients who get the therapy they were hoping for. But also the opposite happens. Patients who know they're in a control group are more likely to report lower than placebo improvement and drop out. So they get a nocebo response. So they're disappointed. They were hoping to get MDMA therapy or psilocybin therapy, but they get a placebo. And they actually feel worse afterwards. And it turns out, with interviews from participants in the MDMA trials on MDMA-assisted therapy, that at least one participant felt forced to lie about the outcomes, receiving a placebo, but actually reporting that they didn't feel that bad, even though their symptoms worsened over time. And giving placebos can also result in adverse effects. So it has also been shown that 25% of patients receiving a placebo actually also experience all kinds of adverse side effects associated with the placebo. Finally, the final problem, the mechanism of action. We've seen all the stories about how psychedelics might reset your brain, increase the connectivity between different brain regions, increase neuroplasticity. But it has recently been pointed out by this paper, Boltav and colleagues, that for all these different mechanisms, there's a high degree of uncertainty whether this mechanism actually is backed up by the relevant empirical evidence. This applies for the pharmacological mechanisms. There's a lot of cherry picking of results going on, of representative graphs. The neural mechanisms, we've seen the nice plot of your increased connectivity of your brain under psilocybin. Well, it turns out that you can get that plot, but it depends a lot on how you analyze the data. And with a different way of analyzing the data, you get a completely different picture. And at the moment, we don't know what the ground truth is. And psychological mechanisms. There's a lot of research going on that's often correlational, but making causal inferences. And we all know that correlation is not causation. So we don't know to what extent psychedelics are actually driving those effects, or if we're tapping into some underlying personality predisposition. So the field is full of conflicting neuroimaging results in small samples and many stories rather than theories of mechanisms. And also the psychotherapy component of psychedelic-assisted therapy is completely under-researched. So we lack standardization and we lack a rigorous evaluation of what therapy works and for what a therapy form is there actual evidence that it can support the use of psychedelics. Well, I want to make a disclaimer. I might come across as very critical, and in the paper we name a lot of examples, and we list a lot of examples for each of these problems. And I think there's a risk of cherry-picking the worst examples that we might be to blame for. Because there are also good examples of high scientific rigor that set a new standard for the field. So in order to now shift gears, I want to take a more positive perspective and actually in the final part of this talk, highlight a couple of good initiatives and examples that have been taken over the past years to address these problems. Another common critique that I frequently face is, well, these problems are not unique to psychedelic science. What makes you think that psychedelic science is the only therapy form, or psychedelic therapy is the only therapy form suffering from all these shortcomings? They also apply to cognitive behavioral therapy, meditation or mindfulness therapy, SSRIs, etc. Well, that's true, but I think psychedelic therapy is unique in a way because all those problems are interrelated and they act in synergy and they all come together and they amplify one another. The breaking blind problem ties in with the placebo effect and that ties in with selection bias and that ties in, well, you name it. And finally, I'm relatively new to the field. I transitioned from doing research on religion and spirituality to psychedelic science and I realized all too good how hard and difficult it is in the first place to get approval for running these studies, to secure funding for setting up this research. It is time-consuming and really challenging to do this in the first place. But then even more so, there's even more reason to do it according to the highest standards possible. So even though it is difficult and it is hard to achieve high sample sizes, let's still try to do the best quality science that we can do. So I think the issue is that these problems are all a problem in and of themselves, but when they all come together, they amplify and they cause concern about any conclusions we can currently draw about the safety and efficacy of psychedelic therapy. But as said, there are solutions. And in the final 15 minutes, I want to go over a couple of the solutions that have been proposed. First off, invalid statistical inferences. Well, we've seen a lot of innovation in the past 10 years in terms of open science practices, including the publication of null results, disclosure of all measures and statistical analysis, sharing de-identified data, for instance in fMRI studies, pre-register hypothesis and analysis plans, for instance on the open science framework, check for the robustness of results by multiple analyst teams, share material, scripts and data, make them available for secondary analysis, use Bayesian statistics with open tools such as, for instance, JASP that allow you quite easily to conduct Bayesian statistics. So these are two examples that I've applied in my own research to test for the robustness of findings. One is multiverse analysis, where you basically conduct all the possible analysis you can think about on your data set, and you simply report, well, out of the 100 analysis I did, in 90 of those analyses I find evidence for the expected effect. That gives you a better confidence in the robustness of your findings. Or a many-analyst approach that we also organized recently with David Yaden and Sean Goldie from Johns Hopkins University, in which multiple teams analyze the same data, and then you can quantify if there's convergence in the conclusions they draw. Just to highlight a good example of a study that I really admired that recently came out. This is a microdosing study on LSD microdosing, assessing effects on cognition, perception, creativity, mood, sleep, etc. I think this is one example of a study that has been pre-registered, high-powered, rigorously conducted. So this is the protocol that you can look up, really according to the best standards we have in open science. And recently a paper came out showing that LSD microdosing increases sleep duration the night after microdosing, a very puzzling finding, but still interesting. So I think this is already showing that the field is improving and that we can see research groups across the world already picking up on these developments as we speak. Conflicts of interest. Well, we can increase the quality of peer reviews by having experts on boards of the editorial boards of journals, including statistical experts, statistical reviewers, exclude reviewers with conflicts of interest, carefully check the manuscript to the pre-registration or the clinical trial gov registration, and check for and reject invalid inferences. And in order to increase transparency, the peer reviews and the author response to the review should also be published. So for instance, in the published findings on the escitalopram versus psilocybin study, there was a debate about the switching of outcome measures. I think that could have been avoided if the peer review process would have been made more transparent, so that reviewers could be held accountable for the reviews they provide. And publish openly researchers' conflicts of interest. Adverse events, safety and adverse events. Well, first off, report them transparently and systematically. Assign independent arbiters in your study protocol to assess adverse events and serious adverse events. Consider also conducting studies in which they are included as primary outcome measure rather than secondary. I just spoke in the break with Gregor Hessler and became aware of the Swiss side effect scale, or was reminded of the Swiss side effect scale, which also can be used in study protocols. Have a protocol and monitoring system in place for safety in the therapy room and provide aftercare. The need for psychological and spiritual support. Think about how you can set it up in your trials. And also in this domain or in this field, new initiatives have been taken, such as, for instance, the Hopkins-Oxford Psychedelics Ethics Work Group. A group of people who come together every year and who have published a statement about the best practices that you can embrace in psychedelic therapy. But also the Challenging Psychedelic Experiences project by Jules Evans, that is carefully documenting adverse events associated with the use of psychedelics, and publishing on that, and making people aware that psychedelics are not for everyone. It might actually trigger feelings of dissociation or recurring hallucinations, so be aware of the risks as well. The lack of control groups. Well, think about what are appropriate control conditions, and this problem, of course, ties in also with the solutions to the breaking blind problem. If you lack resources, think about multi-center studies or multi-center collaborations to allow larger scale studies rather than another open label study. Sample sizes. Think carefully about the effects you're interested in. But also, if you found an effect, conduct a sensitivity analysis to see if you had sufficient power to detect the effect you're actually picking up on. And there are great tools available for this as well. Here's just one, ANOVA Power, an online tool in which you can simply input your expected differences between groups, and that gives you an idea of how many participants you need to include in your trial before you are able to detect a specific effect. Selection bias. Well, first off, more transparent reporting is a solution. Reporting of inclusion and exclusion criteria, reporting of prior drug use and experiences, but also assess other patient characteristics that may be relevant, such as, for instance, socioeconomic status or expectations of treatment that might have an important role, personality, openness to experience, conscientiousness, etc. And in general, recruit more heterogeneous groups of participants, non-weird people. This is also a call we make in this paper. Study duration. Well, ideally, of course, include long-term follow-up measurements. And increase sample sizes, so it ties in with the previous problem, increase sample sizes to mitigate attrition. But also, you can think about implementing new tools to allow you more in-depth assessments of the dynamics of change that might happen as a consequence of a psychedelic experience, such as ecological momentary assessments or dynamic time warping, which are fine-grained techniques that allow you to predict over time which symptoms improve in specific patients. So that gives you a more fine-grained idea of where the mechanism of action might happen for individual patients. The breaking blind problem. Well, first off, we need to report more transparently how often this happens. So instead of 1 out of 10 publications, all publications should report the blind and whether it was broken. Balashigeti has developed a statistical tool to control for the breaking blind problem. So this is a preprint that you can look up. It's an interesting approach to statistically control for this potential problem. But of course, there are other solutions as well, a variety. Using active placebos, dose-ranging strategies, or using different psychedelics within the same trial, comparing a placebo arm to a no-treatment arm, or treatment as usual, comparing a psychedelic condition to other experiential therapies, such as, for instance, breathwork or meditation, or a sequential parallel comparison design, in which you start out with a placebo condition and a psychedelic condition, and you take the people who don't respond to the first condition or to the first assignment, and you again reassign them to a second condition in the second phase of the study. And recently an excellent review paper came out in Nature Mental Health, systematically reviewing all the solutions that have been proposed for the breaking blind problem. I can recommend reading it. Placebo effects. Measuring and reporting treatment expectations is a starting point. Simply measure whether participants believe that psychedelic therapy will prove of benefit to them. The ideal solution would be also to recruit psychedelic naive participants who don't have a conditioned response to a psychedelic. Set realistic expectations by using, for instance, educational scripts. So instead of informing participants that this therapy works for depression, make it very explicit that as of yet we don't know if it works, and that's why we do this study. It might work, it might not work, and that's why we need to find this out very carefully in this study protocol. Selective disclosure of study information, such as, for instance, you might not get psilocybin in a high dose or nothing, but you might get one of the 4 following substances, including psilocybin, MDMA, ketamine, etc. And also informing them about the potential side effects of these substances. And an interesting suggestion that has been made is using a balanced placebo design by independently manipulating whether participants get the active treatment or not and what they're getting, if that is ethically possible. Mechanisms of action, well, a lot of work can be done there as well. Use open science practices, replication studies, and avoid cherry picking of results. So pre-register everything you want to do. And also try to assess the efficacy of, for instance, psychoplastogens. It has already been discussed earlier this morning. There's this debate about whether psychedelics exert the effects they do in terms of the plasticity they induce or through the experiences. And by contrasting psychoplastogens with experiential sessions, there might be a way of figuring that out. And that has been done as well. For instance, by Samuel Kangas-Lampi was, for instance, done a meta-analysis of different clinical trials, and he consistently found that mystical type experiences, the intensity seems to predict therapeutic improvement. So that provides insight in the mechanism of action. Or another study that also picked up on this debate about psychoplastogens versus experience, if investigating the effects of ketamine versus placebo in patients undergoing anesthesia, and surprisingly finding out that both patients group actually improved, and apparently ketamine didn't have an effect. So it might be the experience that makes a difference, or it could be that the anesthetic has antidepressant properties as well. But at least we need more type of studies like this to find out. So this is just to illustrate those points that were mentioned. Concluding remarks. A couple of years ago, we witnessed the psychedelic hype, and I think Helena was quite right in putting the peak of that hype around 2020, 2021, the peak of inflated expectations. And the Gartner hype cycle actually predicts that with any technological intervention or any new therapy form, it will go through the trough of disillusionment to reach the plateau of productivity through the slope of enlightenment. And the question is where we are at the moment. It might be that we have gone through the trough of illusionment already and we're gradually trying to climb the slope of enlightenment. So I will walk you through those 3 phases. So if you take the first part of my talk seriously, I think it is really too early for definite conclusions about the safety and efficacy of psychedelic therapy. Because the synergy between all the problems put psychedelic research on psychedelic therapy in jeopardy. And we really face a credibility crisis to the outside world and to non-psychedelic researchers. And even when appropriate steps have been taken, given the lessons learned from the studies that I started out with, it is still uncertain if psychedelic therapy will be safer or more effective than existing therapy forms. That's really what I see when I critically look at the available data. It works, but it seems to work approximately as well as existing therapy forms, given the way we currently do the psychedelic trials. Then there are concerns about scalability and cost effectiveness. How can we ever scale this up? And it is super expensive to do this therapy, so why should we even want to pursue this? And of course concerns about conflicts of interest, but also researcher and experimental bias. So we face a credibility crisis. But the slope of enlightenment that I see is, one way out is that we need maybe a paradigm change. For instance, one approach is more standardization and more attention to the psychotherapeutic component of psychedelic therapy. Indeed, it might very well be, as David Ertzu pointed out this morning, that we first need to register the medicines and then we can think about the psychotherapy. But at the same time, I think the psychotherapy is completely underdeveloped and unexplored, and there's much to be gained and a lot of wisdom already gained in Switzerland, but also beyond in the psychedelic underground on what works for whom and what the best approach is. But we need more rigorous evaluation of whether there's actually evidence for these different therapy forms and how they might supplement psychedelic therapy. As pointed out already, Helena is making an actually really nice case in this paper for exactly the same point as well. It's time for a paradigm change. It's not only the psychedelic, but it's always in conjunction with therapy that it proves effective. And in that sense, it escapes the logic of standard medicines for evaluation. And secondly, we need to figure out more for which patients this might work. And I think it is really important to keep in mind that all those trials that are currently conducted, or most trials, focus on treatment-resistant patient populations, really hard to treat patients. But in those patients, you need to have some kind of belief, however small, that psychedelic therapy will prove of benefit. There has to be some alignment between the patient's background beliefs, worldviews, and what the therapy has on offer. And I think we need to figure out more closely exactly what type of patients and what worldviews of patients might align well with psychedelic therapy. And in order to do so, or by doing so, hopefully we will soon reach the plateau of productivity, a more realistic understanding of the promises and pitfalls of psychedelic therapy. Because we have a societal problem, of course, as well. Many people are suffering from depression, anxiety, PTSS, for which there's currently no cure available. And we witness a large psychedelic underground, ranging from well-trained psychologists and therapists to self-named shamans. For instance, in the Netherlands, there are many legal psilocybin retreats that are used for treating a variety of disorders that are completely unregulated. So this is already happening at a large scale. And this poses a problem and risks as well, of course, for patients without careful support. So my call is to combine idealism, scientific rigor, with pragmatism. So based on all the concerns I address, I think we really need to do better science, conduct rigorous controlled clinical trials according to the highest scientific standards possible, to actually find out if this therapy is effective and for whom it might be effective. But in parallel, I think we cannot ignore the first problem. So we can think about compassionate use programs and large-scale naturalistic clinical studies. And this was actually an advice also by the MDMA State Committee in the Netherlands, that for a year dive deeply into the nuts and bolts of MDMA therapy and gave the advice we should set up a naturalistic study, giving patients who really need this access to this therapy form, because that way you can collect longitudinal data to see if patients improve, for how long the effects persist, and also what type of patients might respond well to this therapy. You can also use this to train therapists and gain insight in what works for whom. And hopefully by combining idealism with pragmatism, we can finally reach the plateau of productivity and avoid making the errors from the 1960s. That's what I had to say for today. I think we still have time for some questions. Thanks for your attention, and thanks for the invite.
Thank you for your critical but important talk. And as you said, we have around 10 minutes for questions.
Hello, I loved your presentation, but my question is more about if you think that we are repeating history because we are giving the power and we're trying to convince the same system that limited in the 60s, and that if we need to change or shift the factors, the money, the important part to another different perspective, more as a spiritual, more as the community's ancient knowledge, because I think for me, it's kind of the same. We're trying to put money in the same pocket that says to us, no, this is not the way. I will understand, of course, that we're in a medical system and we need to have safety and all of that. But at the same time, I feel that we're giving control and power to the same people that are deciding the pyramid, in a way, and the system, instead of taking knowledge and giving real power and real resources to the main source and the main knowledge, in a way.
Yeah, I don't know if I would subscribe to the idea that we need to go back to indigenous practices for healing. I mean, I'm very much in favor of the outline that Helena sketched earlier today, that you have these different strands, like the recreational use, indigenous use, and then the medical use. And what I spoke about today is very much focused on the medical use of psychedelics, and we need to think carefully about how within that framing we need to improve the rigor of psychedelic science, but at the same time also keep an ongoing discussion with regulatory agencies about what type of evidence they need to be convinced that psychedelics are effective. And maybe also rethinking the logic of the randomized controlled trial, because in many cases the whole logic doesn't add up or doesn't hold up, because psychedelics are not the substance in and of themselves that cure patients. It's always in combination with the expectation, with the setting, with the therapy in which it is amplified. So hence we need maybe to reconsider the criteria for evaluation, and that I think requires an ongoing discussion with the regulatory agencies to see if we can convince them that a paradigm shift might be needed for having a more synergistic or holistic view on how psychedelics should be evaluated. But that is difficult because the whole logic of the system is based on classical medicines that you give, they have a biological mechanism of action, and that's how they cure.
Thank
you. Hi. Nice to meet you in person. I'm Eduardo Schemberg. 4 months ago, I published a letter to the editors in response to your history repeating papers in the same journal. I recently published a preprint that Helena generously and kindly cited in one of her slides today. And one of the things that I've done in this, both in the letter and in this new paper that I don't expect anyone to have read, it's a long paper and it's still a preprint, is to outline that part of the problems to understand psychedelic therapy comes from evidence-based medicine and the ideas behind evidence-based medicine, which curiously also has a pyramid, like the logo of your lab, where RCTs are put on the top as the best scientific method. So I'd like to share 2 stories, tragic stories, of when researchers claim that we can't be sure about anything without rigorous RCTs. The first happened in the 1990s. It's the case of ECMO, extracorporeal membrane oxygenation. It is to these days one of the most effective treatments in medicine. It happens in babies that are born with lung problems and they don't oxygenate their own blood properly. So this blood is driven through a machine that oxygenates the blood and gets back to the same baby's body, all sterilized, hospital and safe. In the 1980s and 90s, when ECMO was created, skeptics were saying we can't be sure that ECMO is really good because these were not randomized control trials. And the creator said we will not conduct these RCTs because we think they are unethical and babies will die unnecessarily. And people did these RCTs and babies died. And it was not only one, it were 3 RCTs of ECMO versus control conditions, and something between 6 and 10 newborns died because people were claiming that without rigorous RCTs, we cannot assess the effectiveness of medical treatments. The second case is more recently, and it happened during the COVID pandemic, where many people said that we could not be sure if masking and masking mandates were effective without RCTs. And potentially millions or hundreds of millions of people were infected because of people claiming for rigor, delaying mask mandates, and disencouraging the population to use masks in an epidemic, a global epidemic of respiratory disease, where it's so obvious that masking should be a good thing to do. So I think what's happening in psychedelic science right now is also reflective of these problems with evidence-based medicine that we already know about. We know so much about it that philosophers of evidence in medicine, for some 10 years now, they're talking about EBM+, which is a different method of assessing evidence for medical treatments. In my letter to you 4 months ago, I highlighted how in your paper you cherry-picked results, which you complain that others are doing when they cherry-pick. And that's not rigor as well. So I super welcome the criticism, but I would say that both part of the research was not rigorous, but as well the criticism is not being rigorous, and that will not help us move forward to make available these treatments to those who need and to those who can safely benefit from it, reminding that no treatment works for everybody, no pill is for everybody to buy and use, SSRIs or benzos or whatever it is. We always need to figure out how to move from trials to population, but honestly, I think the criticism is also exaggerated and falls into some of the same problems that you're criticizing. And I wanted to hear from you about that, because it's 4 months that I published the letter, and you don't seem to have addressed any of my points. Thank you.
Thank you for your critical remark as well. Yes, I'm happy to chat also afterwards. And we reconsidered actually writing a response to the same journal as well, but it got sidetracked and we weren't able to follow up on that. But I think, yeah, your critique is well taken, and that's also why I anticipated in this talk that indeed we're cherry picking, and that is a problem. And we're highlighting the worst examples in the paper that might not be representative of the high quality that's going on, but I also try to mitigate that by showcasing a couple of studies that are actually adhering to those standards. And also pointing out, for instance, meta-analysis that are really well conducted. So the recent meta-analysis on the use of psychedelic therapy for alcohol use disorders, I think is a good example. Really rigorously done, pointing out the statistical flaws in the previous meta-analysis that got unnoted for 12 years. But then still showing that if you put it all together, only the high quality studies that have a low risk of bias, that the evidence does not hold up, that it seems to work, but only temporarily. I mean, and that is the highest level of evidence we currently have. And I also, honestly, don't have the truth myself. I'm just pointing out, this is what I see, and I try to take a humble approach, like, hey, this is what we witness, and we can do better. Regarding your 2 examples, I think that's also indeed a very valid point, but I think that can also be mitigated in the way we set up randomized controlled trials or clinical trials. For instance, by discussing with medical ethical committees, if after a certain point in time it becomes very obvious that one treatment outperforms the other, for instance, using Bayesian statistics where you can really quantify this on a trial or a patient-by-patient basis, and then at a certain point, if the threshold moves towards favoring psilocybin compared to the control condition, that you decide, well, there's no need for further testing because we withhold patients an important therapy form. So I think that is already something we can implement in the way we set up the trials. And also, finally, the last call for pragmatism is exactly also addressing this point, like we need to help the patients who are currently suffering and looking for alternative sources in the underground or elsewhere. And combining one approach doesn't preclude the other, of doing a naturalistic study or using compassionate use programs that also allow to collect data. So that would be my response. But happy to chat also in more detail afterwards.
We have time for one last short question, please. Thank you.
Uh-oh. Is it me?
Hello?
Oh.
2.
Where are you?
I'm here.
Hey.
So hello. Thank you very much for your speech and everything. I have a very short question. It's about, like, in a time where we're more and more speaking about personalized medicine and trying to really spot the patient who can respond to the treatment, maybe would it be an option that psychedelic research is also going to the end or to the limit of the to the science, the journal science that tries to give the same medicine for everyone. So would it be possible that actually it goes in that personal medicine where we should do research on biomarkers or more preclinical tests to be able to maybe predict also the response? Like, do you know whether there is some research about this, or what do you think about this?
Yeah, so my view on that is that the use of biomarkers is always a prediction or a promise that has been made in psychiatry. Once we figure out the biomarker for depression, then we can provide customized precision medicine to patients. But I've not seen one successful application of that, because it is really difficult to find out like what a biomarker is. And there are many small studies showing, for instance, that if you scan brains of patients, that you might be able to predict if they respond well to SSRIs. But those studies typically do not replicate well. So it turns out to be really hard, and that's why I ended with the recommendation. There should be a kind of match between the belief system of the patient and what the therapist has on offer, because in terms of common factors underlying therapies, it turns out that therapeutic alliance is a key predictor of therapeutic improvement. If you, basically in layman's terms, if you're having a good time with your therapist, you improve. And that can be facilitated by psychedelics, but that needs to ensure that you have a kind of match between the worldviews and belief systems of the therapists and the patient. So that is a search process that can maybe be also scientifically investigated, but that is really hard to figure out because it's always also like non-verbal factors or personal factors that are difficult to measure objectively.
Thank you so much, Michiel, and thank you for the questions. Please, one last round for applause for Dr. Michiel Van Elk.
Thank you.